15.1 Primary herpetic gingiva. Pale vesicles and ulcers are visible on the palate and gingivae, especially anteriorly, and the gingivae are erythematous and swollen. Table 15.2 Herpes simplex virus type 2 is more commonly found in, and causes similar disease in, the genital tract, but the viruses are not strictly site-specific, and both types may cause infection at any other site, though less frequently. The virus type is not of clinical significance. Clinical features: the great majority of primary infections are subclinical or completely asymptomatic. Only 1% of people infected develop any symptoms, and these are often minimal. Most patients with clinical infection are children aged younger than 6 years. In clinical disease, vesicles develop on the oral mucosa approximately 7 to 10 days after transmission. The hard palate, gingiva and dorsum of the tongue are favored sites, Figs 15.1-15.3. The vesicles are dome-shaped, tense and filled with clear fluid and increase from 1 mm in diameter to 2 to 3 mm. There are usually tens or more than 100 tiny vesicles. Rupture of vesicles after a day or two leaves circular, sharply defined, shallow ulcers with yellowish or greyish floors and red margins. Initially round, the ulcers enlarge and coalesce to produce more irregular but shallow ulcers. The gingival margins are swollen and red, with or without ulcers. Fig. 15.2 Primary herpetic gingiva. A group of recently ruptured vesicles on the hard palate, a characteristic site. These early individual lesions are of uniform size, but several have coalesced to form larger irregular ulcers. Fig. 15.3 Primary herpetic gingiva. There is diffuse reddening of the attached gingiva with ulceration in the lower incisor region extending beyond the attached gingiva. Fig. 15.4 Herpetic vesicles, a strip of mucosa with underlying normal salivary gland. This is an early infection, and 3 vesicles about 0.5 mm across are seen within the epithelium. The vesicle is formed by accumulation of fluid within the prickle cell layer. Virus-infected cells and debris from lysed epithelial cells are floating freely in the vesicle fluid. Symptoms depend on extent of ulceration, but the ulcers are painful and often interfere with eating. There is usually a degree of fever and systemic upset with enlarged cervical lymph nodes and sometimes a non-specific macular rash. Systemic features can be severe, particularly in adults. Oral lesions usually resolve within a week to 10 days, but malaise can persist so long that an adult may not recover fully for several weeks. Clinico-pathological features: PMID, 18,197,856. Pathology: the DNA virus targets epithelial cells, and replication leads to cell lysis. Clusters of infected cells break down to form the vesicles within the epithelium, Fig. 15.4. Virus-damaged epithelial cells with swollen nuclei and marginated chromatin, ballooning degeneration, are seen in the floor of the vesicle, and indirect smears from early lesions, Figs. 15.5 and 15.6. Infected cells fuse with normal adjacent cells, spreading the infection and forming multinucleate cells. Later, the full thickness of the epithelium is destroyed to produce a sharply defined ulcer associated with an inflammatory infiltrate. Diagnosis: the clinical picture is usually distinctive, box 15.1. A smear showing virus-damaged cells provides additional diagnostic evidence. A rising titer of antibodies reaching a peak after 2 to 3 weeks provides absolute, but retrospective, confirmation of the diagnosis, as does viral culture of vesicle fluid. In cases of severe disease, when the patient is immunosuppressed or complications such as spread to the eye are suspected, rapid definitive diagnosis can be obtained by PCR DNA amplification, ELISA assays, or electron microscopy. These virus-specific tests have the additional ability to reveal that approximately 15% of cases are caused by the type 2 virus that normally causes genital infection, but the symptoms, signs, and treatment are identical. Obtaining a definite diagnosis may not be essential. Hand, foot, and mouth disease and Herpangina, later in this chapter, produce similar features and, if mild, all are treated only by supportive measures. Fig. 15.5 Herpetic vesicle at high power. Running from top left to bottom right is epithelium lining the vesicle. The epithelial cell nuclei are ballooned and pale-stained, mulberry nuclei. Fig. 15.6 A smear from a herpetic vesicle. The distended degenerating nuclei of the epithelial cells clustered together to give the typical mulberry appearance. Treatment: patients feel very unwell, and children fail to eat or maintain fluid intake, sleep poorly, and are fractious. Addressing these concerns is important for children and stressed parents. Because the disease is ultimately self-limiting, supportive treatment may be all that is required. Bed rest, soft bland diet, drinking through a straw, and paracetamol elixir are effective. A non-prescription sedative. Antihistamine will aid sleeping. Chlorhexidine mouthwash is sometimes used in an attempt to reduce pain by controlling secondary infection of ulcers. It also helps maintain gingival health while toothbrushing is impossible. The saliva is infectious, and transfer to the eye must be avoided because ocular herpes infections may develop into encephalitis by direct spread along the optic nerves. Treatment with antiviral drugs is highly effective, but only if administered during the first 48 hours or so after vesicles appear, a maximum of 5 days after prodromal symptoms appear or if new vesicles are developing. Acyclovir is a nucleoside analog that is only phosphorylated by viral DNA-encoded enzymes in infected cells. The activated drug blocks viral DNA synthesis, preventing viral replication. Acyclovir suspension can be used as a rinse and then swallowed for systemic effect or given in tablet form at 400 mg, 3 times per day for 5 days in adults and children older than 2 years. Routine use of antiviral drugs in children is not recommended, and cases should be selected on the basis of severity, accepting that the evidence base is weak and suggests only limited reduction in healing time. BOX 15. 1 PRIMRY herpetic stomatitis, KYFEA TES, usually caused by herpes simplex virus type 1, transmitted by close contact, usually affects children younger than 6 years. Less frequently young adults. Vesicles, followed by ulcers. Affect any part of the oral mucosa, gingiva usually involved, lymphadenopathy and fever of variable severity. Smears from vesicles show ballooning degeneration of viral damaged cells, rising. Titer of antibodies to HSV confirms the diagnosis. Supportive treatment important. Acyclovir very effective if given early after vesicles appear. Older topical antiviral drugs are no longer recommended. Aggressive treatment is essential in people who are immunosuppressed to prevent infection spreading onto the skin or eye and other systemic complications. Valacyclovir is then the preferred drug for its high blood level and longer half-life. Unusually prolonged or severe infections or failure to respond to acyclovir suggest immunodeficiency, and herpetic ulceration persisting for more than a month is an AIDS-defining illness. Acyclovir for child patients PMID, 27,255,621 US treatment guidance PMID, 27,181,443 web URL 15.1 UK NICE treatment guidance. HTTP URL. Latency herpes simplex and zoster are neurotropic as well as epitheliotropic viruses. After the immune response develops and mucosal infection subsides, the virus can remain hidden from the immune response in the sensory nerves that supply the site of the primary infection. Virus is transported back along the nerves from the mucosa to the neuron. Cell bodies in the ganglia where it establishes a lifelong latent infection. During latency there are no symptoms, no virus replication occurs and the patient is not infectious. Reactivation of the latent infection depends on the host cell, not the virus, and triggers, discussed later in this chapter, switch the virus back into replicative infection, after which it travels back down the neurons to reinfect the skin or mucosa. Only a small proportion of the latently infected neurons are able to reactivate, so that recurrent lesions develop only in small foci within the area involved by the primary infection. They are almost always on the lip, herpes labialis, but occasionally in the mouth or on the skin. Rare intraoral recurrence is most frequently on the palate. Many in the population shed virus intermittently into saliva, indicating reactivation of latent infection. They suffer no symptoms but can transmit the infection. Persistent infection and infectivity PMID, 17,703,961 and 24,167,660 herpes labialis summary chart 15.2 page 280 herpes labialis is a secondary infection, that is an infection in an immune individual following reactivation of latent virus. The neutralizing antibodies and T-cell responses produced in response to the primary infection are not protective because the virus travels along the nerves inside neurons from the trigeminal ganglion to infect the lip epithelial cells directly. Reactivation of latent virus to produce a herpes labialis lesion, cold sore, happens in up to 30% of the population, many more than have ever had a clinically evident primary infection. Recurrent lesions must therefore usually follow a subclinical infection. Triggering factors include the common cold, other febrile infections, exposure to ultraviolet light, menstruation, emotional stress, local trauma, hypothermia, dental treatment and immunosuppression, but often none is identified. Clinically, changes follow a consistent course with prodromal paresthesia or burning sensations, then erythema at the site of the infection. Vesicles form after an hour or two, usually in clusters along the mucocutaneous junction of the lips and extending a short distance onto the adjacent skin, Fig. 15.7. The vesicles enlarge, coalesce and weep exudate. After 2 or 3 days they rupture and crust over, but new vesicles frequently appear for a day or two only to scab over and finally heal, usually without scarring. The whole cycle may take as long as 12 days. In patients who are immunocompromised, lesions are larger, more painful and last longer. Secondary bacterial infection may induce scarring. Infectious viruses shed from the lesion until it is completely healed, so a dentist with a cold sore should not work. Recurrent infection can trigger erythema multiforme, ch. 16. Treatment. The need for treatment depends on extent. Many stochal patients manage cold sores with over-the-counter preparations of minimal value. Docosanol is a fatty alcohol with a mild effect. In the UK, Acyclovir 5% cream is available without prescription and may be effective if applied before vesicles appear, when premonitory sensations are felt. Pencyclovir, on prescription, applied every 2 hours is more effective. These agents must be dabbed and not rubbed onto the lesions to avoid spreading the infectious exudate more widely. Sunscreen on the lips prevents lesions in people susceptible to ultraviolet light reactivation. Patients who experience frequent, multiple or large cold sores may benefit from more aggressive treatment with antiviral drugs. Repeated early high-dose treatment both treats the lesion and reduces the risk of future attacks. Vaccines are in trial and have greatest potential benefit in the developing world where herpes simplex infections are a common cause of blindness and are common sexually transmitted diseases, but none is yet approved. Fig. 15.7 Herpes labialis. A. Typical vesicles. B. Crusted ulcers affecting the vermilion borders of the lips. Web URL 15.1 NICE treatment guidance. HTTP URL. US treatment guidance BMID, 27,181,443 Herpetic Whitlow. Both primary and secondary herpetic infections are contagious. Herpetic Whitlow, Fig. 15.8, is a skin infection in a non-immune host after inoculation from another infected site, either another individual or by auto-inoculation. Children with a primary infection may transfer the infection by finger sucking. Routine glove wear has made this a much less common occupational hazard for dental surgeons and their teams. Antiviral drugs should be prescribed as for primary infection. Case and image PMID, 22,546,886 herpes zoster of the trigeminal nerve. Summary chart 15.2 page 280. The varicella zoster virus causes chickenpox in the non-immune, mainly children, later in this chapter. While reactivation of the latent virus in the nerves of immune individuals causes zoster, shingles, mainly in older people. The mechanism of latency is as described above for herpes simplex, but unlike simplex virus, reactivation is a relatively rare phenomenon, and most patients only ever experience a single attack of zoster. Although zoster affects as many as 1 in 3 adults, the face and mouth are relatively unusual sites. Fig. 15.8 Herpetic Whitlow. This is a characteristic non-oral site for primary infection in a non-immune individual as a result of contact with infected vesicle fluid or saliva. The vesiculation and crusting are identical to those seen in herpes labialis. Clinical features: zoster usually affects adults of middle age or older. The first signs are pain and irritation or tenderness in the dermatome supplied by the nerve in which the virus has reactivated after latent infection. Unlike simplex infection, there is severe neuralgic, often burning, pain initially while the virus replicates in the nerve and travels to the skin or mucosa. After 2 to 3 days the pain is felt in the skin and a vesicular rash develops, sharply limited to the dermatome. Facial rash or stomatitis is therefore sharply defined along, and limited by, the midline. Vesicles are usually numerous and can become confluent and pass through the same sequence of rupture, ulceration, crusting and healing as described for herpes simplex infections over 7 to 10 days, figs 15.9 and 15.10. The regional lymph nodes are enlarged and tender. Pain continues until the lesions crust over and start to heal, but secondary infection may cause suppuration and scarring of the skin. Malaise and fever are usually associated. In its prodromal phase, the acute neuralgic pain of trigeminal nerve zoster is a classic mimic of pulpitis, and patients may well present for dental treatment. If no dental cause is evident, this possibility should be considered. This has given rise to the myth that dental extractions can precipitate facial zoster. Pathology: the varicella zoster virus produces epithelial lesions similar to those of herpes simplex. A national program of vaccination against varicella zoster started in the UK in 2013 for people aged between 70 and 80 years and has been recommended in the US since 2017 for those aged over 50 years. Vaccination reduces attacks by approximately half and reduces severity in the remaining patients. Fig. 15.9 Herpes zoster. Erythema and ulcers on the hard and soft palate on the right side and stopping abruptly at the midline. Fig. 15.10 Herpes zoster of the trigeminal nerve. There are vesicles and ulcers on one side of the tongue and facial skin supplied by the first and second divisions. The patient complained only of toothache. Management: herpes zoster is an uncommon cause of stomatitis, but readily recognizable without laboratory investigation, box 15.2, although viral culture and other more rapid tests such as polymerase chain reaction, PCR, are available if required. Mild attacks may require only analgesia and topical soothing cream. Facial infections are usually treated because of the risk of scarring and higher risk of complications. Oral Acyclovir, 800 mg, 5 times a day for 7 days is effective. In patients who are immunocompromised, the drug is continued until 2 days after. Healing and famciclovir or valacyclovir may be preferred. The drug must be given at the earliest opportunity for maximum effect, ideally within 72 hours, and complemented with analgesics. Addition of prednisolone speeds recovery and reduces the incidence of postherpetic neuralgia, ch. 39, but is not usually recommended because the evidence is weak. Use should be limited to older people who are most at risk of postherpetic neuralgia. Any patient who is immunosuppressed, develops complications, has eye involvement or bacterial infection of skin lesions, or is very old or infirm should be managed in a specialist center. Intravenous acyclovir may be required. BOX15. 2 HERPSOSTIOF min ALAREA. KYFEA a recurrent latent varicella zoster infection, prophylactic vaccination available, typically in older people. Pain precedes the rash, facial rash accompanies the stomatitis, lesions localized to one side. Within the distribution of any of the divisions of the trigeminal nerve, malaise can be severe, can be life-threatening in immunosuppression, treat with systemic acyclovir, antibiotics required if the rash becomes secondarily infected. Sometimes followed by post-herpetic neuralgia, particularly in older people. Treatment: PMID, 19,691,461 use of corticosteroids. PMID, 29,431,387 web URL 15.2 Nice guidance. Complications: zoster of the trigeminal nerve will occasionally cause tooth devitalization and even bone necrosis in the affected area, during or after the clinical infection, particularly when the prodromal symptoms included toothache. Involvement of the tip and lateral tip of the nose indicates involvement of the external nasal branch of the nasociliary nerve, a branch of the ophthalmic division of the trigeminal that also supplies the cornea. This is Hutchinson's sign asterisk operator, and it indicates a high risk of ocular involvement and need for specialist treatment from the outset. Fig. 15.11. Zoster in immunosuppression can be a lethal infection if encephalitis develops. Thus, zoster in very old people, organ transplant patients, patients treated for malignant disease or in HIV infection require aggressive treatment and follow-up. Vaccination for people with immunosuppression must use newer recombinant vaccine rather than the live virus vaccine used routinely. Post-herpetic neuralgia mainly affects older people and is difficult to relieve. Ch. 39. Case devitalization: teeth. PMI. Ramsay Hunt syndrome. Ramsay Hunt *operator syndrome is zoster infection reactivated in the facial nerve. Virus is latent in the geniculate ganglion, which houses both sensory and motor fibers. On reactivation, patients develop unilateral facial paralysis, loss of taste on one side of the anterior tongue and vesicles on the tongue, hard palate and in the external auditory canal, all on the same side. It must be differentiated from Bell's palsy. Pain is severe. Fig. 15.11 Typical unilateral zoster rash, sharply defined at the midline, and affecting all three divisions of the trigeminal nerve and the tip of the nose, Hutchinson sign. From Manny's M.J., Holland E.J., 2022. Cornea, 5th ed., Oxford. Elsevier Inc. treatment is as for zoster of the trigeminal nerve, but the chances of full recovery are lower than for Bell's palsy. Cytomegalovirus ulcers. Cytomegalovirus, or herpes virus type 5, is another almost ubiquitous virus that causes an acute primary disease, usually in the newborn, and can remain latent to cause recurrent infection. Almost all infections are asymptomatic. In the few with clinical disease, primary infection resembles infectious mononucleosis, sometimes with painful swelling and infection of salivary glands. The main interest is cytomegalovirus ulceration of the oral mucosa in immunodeficiency, particularly in HIV infection. These ulcers show no specific clinical features but are usually large and shallow and solitary. In people who are immunosuppressed they heal slowly, and biopsy is usually undertaken to identify a cause. The virally infected cells have typical inclusions in their nuclei and can be identified on immunohistochemistry, see Fig. 1.8. Cytomegalovirus infection in immunosuppression is treated with the Acyclovir analog Acyclovir or related drugs. No treatment is required in immunocompetent adults. Review oral signs PMID, 8,385,303 in immunosuppression PMID, 8,705,589 hand, foot and mouth disease summary chart 15.2 page 280 hand, foot and mouth disease is a common viral infection caused by several related strains of enteric viruses, notably Coxsackie A16. These are RNA viruses spread by fecal-oral contact and, distantly, related to poliovirus. Fig 15.12 hand, foot and mouth disease. The rash consists of vesicles or bullae on the extremities. Often they're relatively inconspicuous erythematous patches as here. The disease is highly infectious and often causes minor epidemics among school children and an occasional parent or teacher, often in the autumn. Spread is by droplet, contact and fecal-oral transmission with an incubation period probably between 3 and 10 days. Patients remain infectious for several weeks. The disease is unrelated to foot and mouth disease of cattle. Clinical features: this is a mild viral infection characterized by ulceration of the mouth and a vesicular rash on the extremities. Regional lymph nodes are not usually enlarged, and systemic upset is typically mild or absent, but there may be diarrhea and vomiting. The main features are small, scattered oral ulcers in all areas of the mouth, usually with little pain and an erythematous background. Unlike herpetic stomatitis, intact vesicles are rarely seen and gingivitis is not a feature. The rash develops after the oral ulcers and consists of vesicles, sometimes deep-seated, or occasionally bullae, mainly seen on palms and soles and around the base of fingers or toes, but any part of the limbs may be affected. Fig. 15.12. The rash is often the main feature, and such patients are unlikely to be seen by dentists. In some outbreaks, either the mouth or the extremities alone may be affected. The disease typically resolves within a week. No specific treatment is available or needed, but myocarditis and encephalitis are rare complications. In India and Southeast Asia, disease caused by the less common Coxsackie A6 and A10 is associated with neurological complications and is occasionally fatal. Key features are summarized in box 15.3. Clinical review PMID, 26,087,425 oral features PMID, 1,061,921 more severe variant PMID, 24,932,735 and 27,406,374 Herpangina. This can be considered related to hand, foot and mouth. It is slightly less common than hand, foot and mouth disease and is caused by enteroviruses, of often the same types, but most often by Coxsackie strains. Fig 15.13 Herpangina. Typical cluster of ulcers on an erythematous background on the soft palate. From Cohen J. Powderly W.G. 2004. Infectious diseases. 2nd ed. St. Louis, Mosby BOX15. 3 HAR ND FOOTAND MOUTH DIS EASE. Key YFEA TER-ES, caused mainly by enteric viruses, highly infectious, school children predominantly affected, typically mild vesiculating stomatitis, vesicles and erythema on palms and soles of feet. Rarely severe enough for dental opinion to be sought, no specific treatment available or needed. Herpangina is similar but with no rash. And fewer ulcers. The presentation is a similar mild viral disease with a cluster of a few larger ulcers usually limited to the soft palate. Tonsils or posterior mouth but no rash. Fig. 15.13. As after hand, foot and mouth disease, occasional complications can occur. Herpangina review PMID, 20,118,685 Measles, once a common childhood illness, is now rare following introduction of vaccination schemes in many countries, but there are still approximately 2,000 cases each year due to poor uptake in the UK. Occasional epidemics still occur, but death from measles is now limited to adults, people who are immunocompromised or experience late complications. Worldwide, despite a global vaccination campaign, measles is still the leading cause of vaccine-preventable death. In the prodromal stage of measles, toward the end of a 14-day incubation period, there is fever lasting about 4 days during which Koplik spots form on the buccal mucosa and soft palate. These are characteristic pinpoint foci of epithelial necrosis on a red background, Fig. 15.14. Classically, while these break down into ulcers, the patient develops the typical fever and rash starting on the face. However, the spots are very variable, have been reported to be absent in vaccinated children and also to occur late in the disease. Recognizing Koplik spots is therefore very helpful, but the oral lesions require no treatment. The main effects are the fever, extensive maculopapular rash and cough. Measles resolves in about 3 weeks. Fig. 15.14 Koplik spots in measles, white pinpoint spots on an erythematous background, likened to the appearance of grains of salt. Fig. 16.7 from Paula, A.S., and Mancini, A.J. 2011. Hurwitz Clinical Pediatric Dermatology, a textbook of skin disorders of childhood and adolescence. Philadelphia, Saunders. Measles is highly infectious and has many severe complications, and in the UK is a notifiable disease. In the developing world and in people who are immunosuppressed, it is potentially fatal and predisposes to chancre moris, noma, ch. 9. Case. The UK does not have a universal chickenpox vaccination scheme, and the disease remains endemic, whereas childhood vaccination is recommended routinely in the US. An effective vaccine is available, but use in the UK is limited to protecting those at particular risk of complications, primarily people who are immunosuppressed, women who are pregnant, and non-immune healthcare workers. The formulation of chickenpox vaccine is different from the shingles vaccine because the target populations are different. It is not expected to protect against shingles and may even increase risk of shingles in later life. After a 2-week incubation period, there is malaise, nausea, fever, sore throat, and the rash appears on the face and trunk, producing intensely itchy blisters that break down into ulcers. The oral lesions usually appear before the rash and appear like herpes simplex vesicles and ulcers, except that they tend to occur on the buccal mucosa and palate. There are normally only a few, and numerous ulcers signify a more severe systemic infection. Treatment is mostly supportive, with Acyclovir or related drugs if the diagnosis is made early enough or the patient is at risk of complications. Review in cases PMID, 1,068,230, 6,009, 4 KYFE ter ESOFMPO. Mucosal or skin lesions may also spread via freshly contaminated objects. Incubation period of 4 days to 3 weeks. Initially fever, fatigue and myalgia. Rash resembles chickenpox, face usually, and mouth often, affected. Lesions progress from nodules to vesicles. Bust and ulcerate, heals in 2 to 4 weeks, usually uneventfully, once lesions crossed over the patient is not infectious. Mpox, previously called monkeypox, is a disease of rodents and primates caused by the Mpox virus and previously found only in some African countries around the Congo Basin. Smallpox vaccination produces a cross-reactive immunity, as the viruses are closely related, and when vaccination ceased following smallpox eradication in 1980, the disease appeared and has gradually become more widespread in Central and West Africa. It only occasionally spread to distant countries until 2020 when Mpox appeared in several countries and spread in epidemics, often in men who have sex with men. It is now found in almost all countries but remains rare. Key features are shown in box 15.4. Shortly after infection there are fever, lymphadenopathy, unlike chickenpox, myalgia, backache and fatigue. Then a rash resembling that of chickenpox appears, particularly on the face and limbs. On the skin the lesions are initially flat, becoming raised to form painful papules that often have an umbilicated central depression after 1 to 2 days. These develop into fluid-filled blisters in 5 to 7 days that burst to form an ulcer and crossed over. The number ranges from a few to hundreds, and they may be small, as in chickenpox, or over 10 mm in diameter. In severe disease they coalesce, ulcerating large areas of skin. Healing takes 2 to 4 weeks and is usually uneventful with supportive care. In patients with severe disease, children and people who are immunosuppressed, the untreated disease can be fatal, though anti-smallpox and specific antivirals are available. People vaccinated against smallpox have less severe disease. About half to 3/4 of patients develop oral lesions, and these usually appear before those on the skin. They are less typical than the skin lesions and quickly break down to form ulcers on any part of the mouth, often the lips. Oral lesions often seem to show ulceration spreading from the center like the umbilication seen in skin lesions, Fig. 15.15. As skin lesions are frequent, presentation in a dental setting would be limited to people who have a few lesions on the lips or intraorally or are recently infected. Cases have been reported with a single skin lesion. Oral lesions PMID, 36,096,000. Infection control dentistry. 15.15 Mpox. Target or umbilicated lesions with early breakdown to ulcers seen 2 days after onset of symptoms from Benzlama L, Foy J.P., Bertolis C., 2022. Journal of Stomatology, Oral and Maxillofacial Surgery. 123, 6, 596. The recrudescence of tuberculosis is partly a consequence of the HIV epidemic, partly explained by multiple drug-resistant mycobacteria and partly due to the variable and reduced effectiveness of the BCG, Bacillus calmette-guerin, vaccination. Vaccination is only routine in countries with a high incidence and, when indicated, must be given immediately or soon after birth. Though tuberculosis is common, with over 10 million new cases each year worldwide, oral tuberculosis is rare and only seen as a complication of active pulmonary disease in which the mucosa is infected from the sputum. Trauma is probably required to allow the organisms to access the underlying tissue. Open active tuberculosis itself is now rare in developed countries and tends to be seen in older men with pulmonary infection and a chronic cough that has progressed unrecognized, people who have neglected treatment or are immunosuppressed. They are likely to show typical signs of pulmonary infection, chest pain, malaise, weight loss and hemoptysis. The typical lesion is an ulcer on the mid-dorsum of the tongue. The lip or other parts of the mouth are infrequently affected. The ulcer is typically angular or stellate, with overhanging edges and a pale indurated floor, but can be ragged and irregular. Fig. 15.16. It is painless in its early stages, and regional lymph nodes are usually unaffected. A second typical presentation is a non-healing extraction socket. In both cases, the presentation may resemble a malignant neoplasm. A regular nodular gingival enlargement, with or without ulceration, is seen more rarely. Fig. 15.17. Primary oral tuberculosis is extremely rare, seen essentially only in high-incidence countries, and affects non-immune children and young adults. The presentation is variable with ulcers and gingival swelling. The diagnosis is rarely suspected before biopsy. Case. Fig. 15.16. A tuberculous ulcer of the tongue. The rather angular shape and overhanging edges of the ulcer are typical. The patient was a man aged 56 years with advanced but unrecognized pulmonary tuberculosis. Fig. 15.17. Diffuse gingival enlargement caused by infection from pulmonary tuberculosis from Pi K, Pi km, Mano MK al. 2018. The Lancet Infectious Disease. 18, 11, 1288. Pathology. Typical non-CA seating tuberculous granulomas containing occasional Langhans-type giant cells are seen in the floor of the ulcers. Fig. 15.18. Mycobacteria are sometimes identifiable in the oral lesion by using special stains but can be demonstrated more easily in the sputum. Chest radiographs usually show advanced infection. In tropical countries and in immunosuppression, similar histological features arise from fungal or atypical mycobacterial infections. Management. Diagnosis is confirmed by biopsy, chest imaging and a specimen of sputum. Mycobacterial infection is confirmed by culture or PCR. Interferon gamma release assays used in latent infection are not used to diagnose active infection. Fig. 15.18. Tuberculous ulcer. At the margin, numerous pale staining granulomas are present in the ulcer bed, which fills the right half of the image. The darkly stained multinucleate Langhans giant cells are visible even at this low power. Oral lesions clear up rapidly if vigorous multidrug chemotherapy is given for the pulmonary infection. No local treatment is needed. Syphilis. As a result of contact tracing and early treatment, fewer than 150 cases a year of primary or secondary syphilis were seen in England and Wales in the 1980s. However, since the mid-1990s, the prevalence has risen steadily in developed countries. There are currently approximately 8,000 new cases of syphilis a year in the UK, the highest levels since the 1950s, with incidence tripling since 2010. There are 10,000 a year in the United States, but there is no accurate estimate for Africa where the incidence is highest. This increase is a worldwide trend, and the disease has, for example, become widespread in Eastern Europe. Most of these increases parallel rates of HIV infection and, in developed countries, 2/3 to 3/4 of cases are in men who have sex with men. HIV infection predisposes to a fulminant form of the disease and also renders some diagnostic tests based on antibody levels inaccurate. Oral lesions in each stage of syphilis are clinically quite different from each other. Oral lesions in the UK probably often pass unrecognized outside specialist clinics. Congenital syphilis arises when an infected mother transmits the infection to her child in utero or during birth. After almost vanishing in the developed world, congenital infection is now seen again, even in developed countries, and worldwide it causes the death of 500,000 infants each year. Survivors usually develop either latent or tertiary syphilis. The widespread infection produces many signs and developmental disturbances, classically diffuse rash, lymphadenopathy, rhinitis, radial scarring around the mouth and periostitis of many bones producing a saddle nose and frontal bossing. The classical triad of interstitial keratitis of the cornea, sensorineural hearing loss and dental anomalies is diagnostic. Dental anomalies are discussed in Chapter 2. Fig. 15.19. Primary chancre. The lower lip is a typical site for extragenital chancres, but they're rarely seen. UK incidence PMID, 26,931,054. US incidence PMID, 26,562,002. They appear 2 to 10 weeks after infection and may form on the lip, tip of the tongue or, rarely, other oral sites. A chancre consists initially of a firm nodule about a centimetre across. Fig. 15.19. The surface breaks down after a few days, leaving a rounded ulcer with raised indurated edges. Chancres are usually solitary, and multiple lesions suggest immunosuppression. A chancre is typically painless. Regional lymph nodes are enlarged, rubbery and discrete. A biopsy may only show non-specific inflammation, but sometimes there is conspicuous paravascular infiltration by plasma cells. If infection is suspected, immunohistochemical staining can reveal the treponema organisms in the epithelium, but the diagnosis is easily missed if not suspected clinically. Diagnosis is best made by serological tests or polymerase chain reaction. Biopsy can be diagnostic, though rarely performed, but direct examination of smears from oral lesions is not recommended because treponema pallidum cannot be confidently distinguished from other oral commensal spirochetes. After 8 or 9 weeks the chancre heals, often without scarring, but while present is highly infectious. Unfortunately, the diagnosis of syphilis is rarely made at the primary stage. Secondary syphilis. The secondary stage develops 1 to 4 months after infection as the causative spirochetes spread to other tissues. It typically causes mild fever with malaise, headache, sore throat and generalized lymphadenopathy, soon followed by a rash and stomatitis. The rash is variable but typically consists of asymptomatic pinkish, coppery macules, symmetrically distributed and starting on the trunk. It may last from a few hours to several weeks, and its presence or history is a useful aid to diagnosis. Oral lesions, which rarely appear without the rash, mainly affect the tonsils, lateral borders of the tongue and lips. They are usually flat ulcers covered by greyish membrane and may be irregularly linear, snail's track ulcers, or, most commonly, coalesce to form well-defined rounded areas, mucus patches, Fig 15.20. Condyloma lata are raised mucus patches, Fig 15.21, that resemble large flat papillomas. Oral lesions may mimic pemphigoid, pemphigus, lichen planus, erythema multiforme and other causes of widespread ulcers and inflammation. Fig. 15.20 Secondary syphilis, a large mucus patch on the palate. Discharge from the ulcers contains many spirochetes, and saliva is highly infectious. Serological reactions, see later in this chapter, are positive and diagnostic at this stage, and biopsy is diagnostic using T. pallidum-specific immunohistochemical stains, Fig 15.22. Untreated secondary syphilis becomes latent, non-infectious and asymptomatic but carries the risk of developing tertiary disease. Tertiary syphilis. Late-stage syphilis develops in patients approximately 3 or more years after infection in as many as a third of untreated patients but not in those treated effectively. The onset is insidious, and during the latent period the patient may appear well. The late tertiary stage is now very rare in developed countries but remains common worldwide. Leukoplakia of the tongue may develop during this late stage, ch. 19, and other effects of syphilis such as aortitis, tabes or general paralysis of the insane may be associated. The characteristic oral lesion is the gumma, usually of the palate, tongue or tonsils. This starts as a swelling a few to several centimeters in diameter, sometimes with a yellowish center that undergoes necrosis, leaving a painless, indolent, deep ulcer. The ulcer is rounded, with soft, punched-out edges. The floor is depressed and pale, wash leather, in appearance. It eventually heals with severe scarring that may distort the soft palate or tongue, perforate the hard palate, Fig. 15.23, or destroy the uvula. Microscopically, there is non-specific inflammation with endarteritis and sparse granulomas. However, the appearances can be completely non-specific, and diagnosis depends on laboratory tests. Biopsy is often not diagnostic because the number of T. pallidum is very small, a gumma being primarily an immunologically driven hypersensitivity reaction rather than an infective focus. Review oral lesions BMID, 15,953,910 and 33. Clinical diagnosis and biopsy. Diagnosis with confirmation of treponema by immunohistochemistry is the likely pathway in most cases, presenting to dentists as the diagnosis is not usually suspected and a biopsy may well be taken. Fig. 15.21 Secondary syphilis, multiple raised flat mucus patches or condyloma lata courtesy drive J. Cetaphil. When the diagnosis is suspected, specialist testing must be sought as interpretation of the results is complex. Positive test results may indicate past rather than active disease, and other sexually transmitted diseases or HIV infection may also be present. The organism cannot be cultured and serological tests are used. Until recently, the specific fluorescent antibody tests and T. pallidum hemagglutination or particle agglutination assays were the most specific. Although widely used, the VDRL test is a screening test of low positive predictive value and multiple tests had to be used. Gradually these tests are being replaced by PCR-based rapid molecular assays of very high sensitivity and specificity. Tests indicate the infection, but not the stage. Benzathine penicillin is the drug of choice, an intramuscular preparation with slow absorption. Syphilis in HIV infection requires more aggressive treatment. Fig. 15.22 Secondary syphilis. On the left in routine H&E stain the features are non-specific, with numerous neutrophils in the epithelium and a dense plasma cell infiltrate below. Immunohistochemistry for T. pallidum, in the center, reveals very abundant spirochetes in the epithelium seen as yellow-brown staining. Right, at high power, the shape of individual spirochetes can be seen around the epithelial cells. Fig. 15.23 Tertiary syphilis, gummas of the palate. Necrosis in the center of the palate has caused perforation of the bone and 2 typical round punched-out holes. Candidosis asterisk operator can be caused by several species of Candida, but in 80% of infections the organism is Candida albicans. All are normal commensals in the mouths of a third or more of the healthy population, and many more among denture wearers, individuals with dry mouth and older people. This Candida carriage is not associated with symptoms or disease, and the number of organisms existing as commensals is relatively small. Candida sp. is dimorphic. Carriage is associated with the yeast, blastospore, form, but only the invasive hyphal form causes disease. The reasons for the organism switching to a pathogenic form, phenotype switching, are unclear, but disease seems to follow some change to the oral environment. Thus, host factors are probably more important than fungal factors. After switching, Candida becomes more adhesive, secretes pathogenic enzymes and is more resistant to killing by neutrophils. The most common pathogenic species is Candida albicans. Candida glabrata, tropicalis and cruce and other less frequent species account for some 20% of disease between them. Some of the less frequent isolates are reported to be more likely to develop resistance to antifungal drugs, but this remains a relatively rare problem clinically. The concept that candidosis is a disease of the diseased dates from 1868, and many medical factors are recognized to predispose to infection, box 15.5. These are likely to influence adhesion of the yeast form to the epithelial cells, which seems to trigger development of invasive hyphae. When the yeasts adhere, they trigger host cell receptors to activate an innate host response and attract neutrophils into the epithelium. Hyphae are only able to invade a limited distance into the epithelium, only within keratin and the upper prickle cell layer. Oral candidiasis is a very superficial infection, explaining its mild symptoms. However, weakened innate and adaptive immunity carry a risk of invasive deep infection and hematogenous spread. Microbiology Candida biofilms PMID, 21,134,239 controversies in candidiasis PMID, 22,998,462. There are various classifications of oral candidiasis, but in reality these diseases merge into one another and can coexist. Thus, infection causes a spectrum of distinctive presentations, rather than separate diseases. Box 15.6. The commonest forms are thrush, chronic hyperplastic candidiasis and denture stomatitis. Chronic mucocutaneous candidiasis is discussed later in this chapter and in chapter 37. Thrush summary chart 15.1 and 19.1 pp. 279, 347 thrush operator, a disease recognized by 279, 347 thrush operator, a disease recognized by Hippocrates, is also sometimes called the acute pseudomembranous type of candidiasis because of the thick white layer of candidal hyphae, dead and dying epithelial and inflammatory cells and debris that covers the mucosa like membrane. Thrush is common in neonates, caused by lack of an immune response and infection acquired during passage through the birth canal. It is also common in people who are very old or very debilitated and on the soft palate of asthmatic steroid inhaler users who spray their palate rather than inhale the drug. It may also follow antibiotic treatment. BOX15. 5-OILCAN didoesis, IMPO-RTAR NTPRE DISPO S in GFACTRS, develops often at the extremes of age, immunodeficiency, diabetes mellitus, HIV infection, chemotherapy. Immunosuppression, including steroid inhalers. Anemia, of any type, suppression of the normal oral flora by antibacterial drugs. Xerostomia, denture wearing, orthodontic appliance wearing, poor oral hygiene, smoking, high carbohydrate diet, epithelium with increased keratin. For instance in lichen planus and dysplasia, almost any severely debilitating illness, treatment for malignant disease BOX15. 6 BCTR MOFOILCAN dido-S is acute candidiasis, thrush, acute antibiotic stomatitis, chronic candidiasis, denture-induced stomatitis, chronic hyperplastic candidiasis, erythematous candidiasis, chronic mucocutaneous candidiasis, angular stomatitis XXX. Rarely, persistent thrush is an early sign of chronic mucocutaneous candidiasis or candida endocrinopathy syndrome, ch. 37. Clinical features. Although classified as acute, thrush may have a rapid onset or develop insidiously from a chronic infection, and in people who are immunosuppressed it may become chronic. Thrush forms soft, friable and creamy-colored plaques on the mucosa, Fig. 15.24, and the pseudomembrane can be scraped or wiped off, exposing the erythematous mucosa below. This differentiates thrush from chronic forms of candidiasis in which the white surface layer is keratin. The extent of pseudomembrane varies from isolated small flecks to widespread confluent plaques, and the buccal mucosa, palate and dorsal tongue are the most commonly affected sites. Angular stomatitis is frequently associated, as it is with any form of intraoral candidiasis. The condition is not painful, rather it is uncomfortable, sometimes with a bad taste or burning sensation. Pathology or periodic acid Schiff, PAR, stain scraping from the pseudomembrane shows large masses of tangled hyphae, detached epithelial cells, fibrin exudate and neutrophils, Fig. 15.25, and finding hyphae is diagnostic. Biopsy is not necessary but would show hyperplastic edematous epithelium infiltrated by neutrophils. Staining with PAR shows many candidal hyphae growing down through the epithelial cells to the upper prickle cell layer, Fig. 15.26. More deeply, the epithelium is hyperplastic, with long, slender RT processes extending down into the corium and the lymphoplasmacytic infiltrate below. Fig. 15.24 Thrush. The lesions consist of soft, creamy patches or flecks lying superficially on an erythematous mucosa. This soft palate distribution is particularly frequent in patients using steroid inhalers. Fig. 15.25 Direct scraping from thrush. The tangled mass of gram-positive hyphae of Candida albicans is diagnostic. A few yeast cells may be present as well, but it is the presence of hyphae that is diagnostic. Key features are summarized in box 15.7. Management. The diagnosis is made on clinical features supported by microscopy of a scraping. The infection itself is managed by dealing with any identifiable predisposing factors, and this alone may allow thrush to resolve. However, usually a course of topical antifungal is first-line treatment. The treatments for Candida infection and their indications are given in Appendix 15.1. A search must also be made for predisposing conditions in the medical history and oral examination, and they must be treated or ameliorated if possible. Denture wearers will benefit from the denture hygiene regime outlined below for denture-induced stomatitis. Fig. 15.26 Thrush. At high power, the surface layers of the epithelium are separated by inflammatory edema and are colonized by fungal hyphae, A, and infiltrated by neutrophils, B. The infection is always very superficial. The lower edge of the image is at the level of the epithelial prickle cells. BOX15. 70 RSH, KYFEATES, acute onset candidiasis, sore rather than painful, secondary to various predisposing factors, box 15.4. Common in HIV infection and indicates weak immunity, creamy soft patches. Readily wiped off the mucosa, smear shows many gram-positive hyphae, histology shows hyphae invading superficial epithelium, responds to topical antifungals though systemic, often used anemia or some cause of immunosuppression, usually HIV infection. Should be suspected when thrush is seen in an adult in whom there is no detectable predisposition. These are also suggested by failure to respond to treatment or recurrent disease. In immunosuppression, specialized advice must be sought as recurrent thrush indicates marked suppression and extension to the esophagus is a significant complication. Web URL 15.3 NICE Treatment Guidance UK. HTTP URL. US Guideline PMID, 26,679,628, see Section 16 Inside Angular cheilitis Summary Chart 15.1 Angular cheilitis or angular stomatitis is an infection at the commissure of the lips, typically caused by leakage of Candida-infected saliva at the angles of the mouth. It can be seen with thrush. In infants, in denture wearers, in association with chronic hyperplastic candidosis or alone. It is a characteristic sign of candidal infection, though a minority of cases are caused by bacteria. Fig. 15.27 Angular stomatitis. Cracking and erythema at the commissure is due to leakage of saliva containing Candida albicans, constantly reinfecting the saturated skin. Clinically, there is mild inflammation at the angles of the mouth with painful fissuring or cracking and sometimes a soft crust. Severe lesions may bleed. The morphology of the lips, commissure and skin contribute to the condition. The commissure is normally dry and lightly keratinized, but in patients with angular cheilitis it is usually wet, either from saliva leakage or from deliberate licking or application of moisturizers or similar materials. Saturation of the keratin allows Candida to infect the epithelium. In older people, the commissure communicates with folds of skin caused by loss of elasticity and sagging of the facial tissues with age, and inflammation and infection may then extend onto the skin. Fig. 15.27. Management. Angular cheilitis is a mixed infection. Candida is found in as many as 90% of cases, but the proportion varies in different populations, being higher in denture wearers. Staphylococci, streptococci or other pathogens are frequently present, and exactly which organisms are causative is unclear. Treatment is targeted at the intraoral reservoir of candidal infection using local measures and antifungal drugs as appropriate. In mild cases, this alone causes angular stomatitis to resolve. Miconazole gel is the ideal first-line treatment for the commissures as it has additional activity against several gram-positive bacterial species including staphylococci and can be expected to successfully treat almost all cases. Failure is more likely due to incomplete treatment of the intraoral infection, but if this appears controlled, changing to 2% fusidic acid cream for the angles on assumption of staphylococcal or streptococcal infection is logical. There is a particularly high proportion of patients with anemia as a predisposing cause in angular cheilitis, and iron, folate and vitamin B12 levels should be checked. In people who are edentulous, have lost lip support or have prominent skin folds, attempts to correct vertical dimension or thicken the labial flange cannot usually remove these susceptible areas. Dermal fillers have been tried, produce good cosmetic results, but so far remain without a good evidence base for preventing infection. Fig. 15.28 Erythematous candidosis, irregular patches of erythema on the palate of a patient using a steroid inhaler. BOX15. 8 TYPESOFERYTHE MARTA CAN Dido is acute antibiotic stomatitis, median rhomboid glossitis, denture stomatitis, erythematous candidosis. Erythematous candidosis summary charts 15.1 and 19.3 pp. 279, 349. This term is now applied to any candidal infection that produces red mucosa. Originally the name was used to describe the chronic red form of candidosis seen on the palate and gingiva of HIV-positive patients, see Fig. 30.6. However, the name was not very specific, and similar changes can arise in the immunocompetent, sometimes caused by a mixed infection with a bacterial and candida component. The term is now taken to include a number of presentations with a primarily red mucosa, either localized or generalized. There may be occasional white flecks on the red background, but no pseudomembrane. Fig. 15.28. If a candidal infection produces a red area but does not fit the descriptions of the specific conditions listed in box 15.8, it can simply be described as erythematous candidosis. Such lesions are usually on the hard palate, dorsum of the tongue and soft palate, and are usually associated with immunosuppression or steroid inhalers as an underlying factor. Web URL 15.3 NICE Treatment Guidance UK. HTTP URL. US Guideline PMID, 26,679,628, see Section 16 Inside Acute Antibiotic Stomatitis Summary Chart 15.1 page 279. This condition is also known as antibiotic sore mouth and acute atrophic candidosis. It follows overuse or topical oral use of antibiotics, especially broad-spectrum drugs such as tetracycline. These suppress the normal oral flora that competes with candida in the mouth, allowing its overgrowth. Fig. 15.29 Glossitis in antibiotic-induced candidosis. The tongue is red, smooth and sore as in anemia, but the appearance results from inflammation and edema. Similar changes affect other parts of the mouth, and there is angular cheilitis. Clinically, the whole mucosa is red and sore, but the tongue is typically worst affected and appears smooth, having lost its filiform papillae. Fig. 15.29. A few flecks of thrush may be present. Resolution may follow withdrawal of the antibiotic but is accelerated by topical antifungal treatment. A similar but chronic generalized candidal erythema can also be a consequence of xerostomia and is a typical complication of Sjogren's syndrome. Web URL 15.3 NICE Treatment Guidance UK. HTTP URL. US Guideline PMID, 26,679,628 see Section 16 Inside Median Rhomboid Glossitis Summary Charts 15.1 and 19.3 pp. 279, 349 median rhomboid glossitis produces a red patch in the midline of the dorsum of the tongue at the junction of the anterior 2/3 with the posterior third, classically in a diamond shape. It has historically been proposed to be a developmental condition, but it is not seen in children and has nothing to do with persistence of the tuberculum impar or development of the thyroid. However, not all lesions can be shown to be infected with Candida. It seems that this presentation has a very low level of infection. Infection is probably intermittent and permanently damages the mucosa so that it loses its ability to form papillae and appears red even when infection is absent or inactive. Median rhomboid glossitis is relatively common and is found in 1% to 2% of the population. Clinically, median rhomboid glossitis is seen in adults and is typically symptomless. Its color ranges from pink to red, and the affected area has lost its filiform papillae, Fig. 15.30. Usually the patch is smooth, flat or appears slightly depressed, but in long-standing lesions it may develop nodules. In the few cases with more intense infection, white flecks may be seen, Fig. 15.31. A florid lesion may appear worrying and be mistaken for a carcinoma, particularly when nodular, but squamous carcinoma virtually never develops at this site. One factor that may predispose to infection at this site is that, in many individuals, this part of the tongue rests against the soft palate, trapping saliva, and so is not as self-cleansing as the rest of the tongue. Sometimes a matching patch of candidosis is present on the soft palate at the site of contact. Fig. 15.30 median rhomboid glossitis. The typical lozenge-shaped area of depopulation in the midline of the tongue, made more prominent in this patient because of the prominent tongue furring. Fig. 15.31 median rhomboid glossitis. There is a whitish patch centrally in the depopulation, overall with sharply demarcated borders in the midline of the tongue at the typical site. Histologically, the appearances are variable. The primary change is epithelial atrophy with loss of filiform papillae and often broad parallel-sided reactive-process hyperplasia. Fungal hyphae should be sought but often not found or are very sparse. Below the epithelium in long-standing cases there is a broad band of dense scarred fibrous tissue, Fig. 15.32, that makes the lesion feel indurated. Nodules arise by inflammation-induced fibroepithelial hyperplasia. Case series and images PMID, 21,912,494 case series PMID, 366,496. Management diagnosis is based on clinical appearance, and reassurance is usually the main requirement. Antifungal treatment does not usually resolve the lesion and should not be considered unless a scraping is positive for hyphae on microscopy. Nodular or lobulated lesions do not resolve on antifungal treatment and filiform papillae may be lost permanently. A biopsy should not be required. Fig. 15.32 median rhomboid glossitis with epithelial reactive-process hyperplasia, light inflammation below and a band of scar tissue, A. Fig. 15.33 typical denture stomatitis. Clear demarcation between the erythema of the mucosa covered, in this instance, by an orthodontic appliance and the palate behind the posterior margin is clearly seen. Denture-induced stomatitis summary charts 15.1 and 19.3 pp. 279, 349a well-fitting upper denture cuts off the underlying mucosa from the protective action of saliva and provides a space in which the oral flora, including Candida, can proliferate freely. In susceptible patients, particularly smokers, this can promote candidosis, seen as a symptomless area of erythema. The erythema is sharply limited to the area of mucosa occluded by the upper denture or orthodontic appliance, Fig. 15.33. Similar inflammation is not seen under the more mobile lower denture, which allows a relatively free flow of saliva beneath it. The exact relationship between the denture, candidal infection and denture-induced stomatitis remains somewhat contentious. In the past, the denture has been seen as the cause, either through poor fit, allergy, or irritation. Candida infection is definitely present, but hyphal forms are sparse and the inflamed mucosa may be reacting to either Candida or bacteria in the biofilm adherent to the denture rather than being invaded. Biopsy shows inflammation in the tissues and occasional fungal hyphae at the surface. Evidence for the importance of Candida comes from the fact that angular stomatitis is frequently associated. Management: the clinical picture is distinctive, but the diagnosis can be confirmed by finding candidal hyphae in a smear from the inflamed mucosa or the fitting surface of the denture. Quantification of Candida in saliva is of little value as candidal carriage is common and counts are higher in denture wearers. The infection responds to antifungal drugs but recurs unless the denture factors are addressed. Topical agents such as Nystatin can only gain access to the palate if the patient leaves out the denture while the medication is in the mouth. Systemic fluconazole is often used, Appendix 15.1. Porosity voids in methylmethacrylate denture bases also harbor C. albicans and dentures may therefore form a reservoir that can reinfect the mucosa. Elimination of C. albicans and bacterial biofilm from the denture base is important and can be achieved by brushing and soaking the denture in dilute chlorhexidine mouthwash overnight. A key predisposing factor is night wear of dentures. Ceasing this alone may allow resolution. A simpler alternative is to coat the fitting surface of the denture with meconazole gel while it is being worn. The denture should be removed and scrubbed clean at intervals and meconazole reapplied 3 times a day. This treatment should be continued until the inflammation has cleared and C. albicans has been eliminated. This is likely to take 1 to 2 weeks, but patients should be warned not to continue this treatment indefinitely. Resistance to meconazole is growing and the oral gel can be absorbed. Using meconazole gel on a denture in this way is contraindicated in patients taking warfarin or phenytoin because sufficient meconazole is absorbed to enhance their effects. Lack of response may be due to poor patient compliance or to an underlying disorder, particularly iron deficiency. Systemic antifungal drugs without local measures are ineffective. Key features are summarized in box 15.9. Web URL 15.3 NICE Treatment Guidance UK. HTTP URL. US Guideline PMID, 26,679,628, see Section 16 Treatment PMID, 24,971,864 Papillary hyperplasia of the palate. Extensive nodular fibroepithelial hyperplasia of the palate has often been considered a complication of candidosis, but candida alone is not the cause. This condition is discussed in Chapter 24. Chronic hyperplastic candidosis. Summary charts 15.1, 19.1 and 19.2 pp. 279, 347, 348. The alternative name of candidal leukoplakia reveals the controversial nature of this condition, in which chronic low-level candidosis induces a localized zone of epithelial keratosis. Unfortunately, candida will also readily infect the keratotic lesions of true leukoplakia, ch. 19, to produce the same clinical appearance. As many leukoplakias have no specific features, it may not be possible to tell these two situations apart. However, a white patch caused entirely by candidal infection carries a minimal or no risk of developing squamous carcinoma. Fig 15.34 Chronic hyperplastic candidosis, typical appearance and site just behind the commissure. The surface is usually flat or may be tessellated as here. In long-standing infection, the surface may become slightly nodular. No erythema is present and candida hyphae would be sparse on biopsy. BOX15. 9D enter in duci di estomatitis, key YFEA TES, candidal infection promoted by well-fitting upper denture. Enclosed mucosa is cut off from protective action of saliva. Mucosal erythema sharply restricted, the area covered by the denture, hyphae proliferate in denture mucosa interface and denture biofilm. Bacteria in denture biofilm contribute to the inflammation. Angular stomatitis frequently associated, diagnosis by smear of mucosa or denture, resolves after elimination of Candida albicans by antifungal treatment and improved denture hygiene. Clinical features: adults. Typically males of middle age or older are affected, and most are smokers. The usual sites are the post-commissural buccal mucosa and the dorsum of the tongue. The plaque is variable in thickness, often rough or irregular in texture and tightly adherent. Fig. 15.34. It will not rub off. Angular stomatitis may be confluent with plaques on the post-commissural mucosa. When the Candida infection is more florid, lesions develop an erythematous background or speckling and resemble speckled leukoplakia, strongly resembling a high-risk lesion for developing carcinoma. Fig. 15.35. Pathology: the surface epithelium is parakeratotic and contains candidal hyphae. They are often sparse and elicit little or no inflammatory response, just a few neutrophils focally. Par stain shows the hyphae growing, as in thrush, directly through the epithelial cells of the keratin layer, figs 15.36 and 15.37, to the prickle cell layer, but no. Further, Candida induces mild epithelial hyperplasia, and often their long parallel-sided retroprocesses. Inflammation in the connective tissue is mild. Fig. 15.35 Chronic hyperplastic candidosis. This more florid infection is white and nodular with erythema, suggesting fungal infection clinically but also raising concern about potential malignancy. Candidal hyphae would be frequent in a biopsy. If dysplasia is present on biopsy, the lesion is a leukoplakia with superimposed candidal infection and not chronic hyperplastic candidosis. Management: after confirmation of the diagnosis by histology or scraping for hyphae, antifungal treatment is provided, but eradication of infection is difficult in this chronic infection. Usually, meconazole gel is effective but may need supplementing with a systemic antifungal drug such as fluconazole for 2 weeks. Accompanying angular cheilitis needs concurrent treatment, and denture hygiene and efforts to reduce the oral load of Candida are required as described for denture stomatitis. Underlying anemia may contribute and should be treated first, and ideally smoking should cease. These interventions not targeted to the lesion itself are often the key to success. Long-term intermittent antifungal therapy may be required. Excision of the candidal plaque alone is of little value, as the infection can recur in the same site even after skin grafting. If, after all these interventions, the plaque remains, consideration must be given to the fact that it may be a leukoplakia with superimposed Candida infection and require follow-up as a potentially malignant lesion. Although a potential for malignant change is generally thought to exist, this is contentious and the risk is very low and probably absent. Review PMID, 12,907,694 Chronic mucocutaneous candidosis syndromes. Summary chart 15.1 page 279. These syndromes are all rare, but difficult to manage. Classification is complex now that many types can be classified by their causative genes. The significance of these conditions is to recognize them when chronic Candida infection presents with very florid involvement, particularly of skin, nails and mucosa, proves resistant to treatment, or presence in childhood or adolescence. Fig. 15.36 Chronic hyperplastic candidosis. Thin parakeratin at the surface, long parallel-sided retroprocesses and a few inflammatory cells immediately below the epithelium, left. At higher power, right, a few Candida hyphae in the keratin, appearing as magenta-colored tubes in cross-section in periodic acid Schiff, PAR, stain. Fig. 15.37 Electron micrograph showing 2 Candida hyphae, very dark, growing through superficial keratinocytes of the oral mucosa. Note how they penetrate through the cells and do not grow around them. All seem to be caused by immunodeficiency that is relatively selective for fungi or Candida in particular, and one type is autoimmune. Family history is variable. General Review PMID, 20,859,203 Autoimmune polyendocrine syndrome I or endocrine candidosis syndrome is defined by hypoparathyroidism, adrenocortical insufficiency and chronic mucocutaneous candidosis, though many other features can present before the classical features are evident, box 15.10. Inheritance can be autosomal recessive or dominant, and onset is in the first 2 decades of life. Failure of an immune regulator gene allows autoreactive T cells to escape deletion in the thymus during development. There are multiple autoantibodies to endocrine glands and against interferons, which are diagnostic. Candidosis is usually the presenting feature with thick plaques and red areas at any or all sites in the mouth, Fig. 15.38, spreading to the pharynx and esophagus. Fig. 15.38 Chronic mucocutaneous candidosis, extensive red and white patches throughout the oral mucosa and angular cheilitis. BOX15. 10 Fe ater ESOFA uto immune po len do crossing in ES undoct OMI, genetic, usually autosomal recessive, hypoparathyroidism. Adrenocortical insufficiency, chronic mucocutaneous candidosis, type 1 diabetes, autoimmune keratitis of the eye, malabsorption and diarrhea, autoimmune hepatitis. This form of candidosis is potentially malignant, and 20% of patients develop oral or esophageal carcinoma. Treatment of the candida infection must be aggressive and involves multiple agents. In children, care must be taken to avoid finger sucking as infection will spread to wet skin and may then be intractable, Fig. 15.39. Hypoplastic dental defects are frequently also present. General Review PMID, 15,141,045 and 30,510,005, Fig. 15.39 Chronic mucocutaneous candidosis, damage to fingernails through chronic infection in one of the more severe types. Pathogenesis PMID, 34,455,138 other types of mucocutaneous candidosis are recognized, with variable inheritance, severity and specific gene defects. Some arise from autoimmune failure as a result of major histocompatibility complex gene mutations, and others are associated with autoantibodies to interleukin-17, SDAT1 mutations reducing levels of interleukin, IL-17 or other cytokines, or defects that compromise killing of candida by neutrophils. Mild forms are indistinguishable from sporadic cases of chronic hypoplastic candidosis histologically, Fig. 15.40. More severe forms may have susceptibility to bacterial infection or a range of other diseases. Thymoma and myasthenia gravis are associated with those types with autoantibodies against IL-17. Candidosis. At high power, the thick parakeratin layer at the surface of this lesion is seen to be invaded by numerous fungal hyphae, as seen in simple chronic hypoplastic candidosis. Summary chart 15.1 Summary of the types of oral candida infection and their management. Summary chart 15.2 Differential diagnosis and management of the common and important causes of multiple oral ulcers with acute onset. Appendix 1.5. 1 RECO MMENDATONSFORTREATMENTOFOILCAN. Chapter 16. Diseases of the oral mucosa, non-infective stomatitis ulcers. Summary charts 16.2 and 16.3 pp. 311, 312 ulcers are full-thickness breaks in the continuity of the epithelial covering of the mucosa, exposing connective tissue to the mouth, and the general features are discussed at the start of chapter 15. Clinically, dividing ulcers into those that are persistent and those that are recurrent is a useful first step in differential diagnosis. Most oral ulcers heal after a few days to 2 weeks depending on their size, more rapidly on the floor of mouth or buccal mucosa than on the palate or gingiva. Recurrent oral ulcers are those that recur singly or in crops at the same or different sites. Recurrent ulcers have few common causes. It is important to distinguish recurrent oral ulceration, a presentation of several diseases, from recurrent aphthous ulceration, recurrent aphthous stomatitis, which is a specific condition. General Review Diagnosis Ulcers PMID, 26,650,694 Traumatic ulcers. Summary chart 16.2 and 16.3 pp. 311, 312. Traumatic ulcers are usually caused by biting, denture trauma or chemical trauma and arise at trauma-prone sites such as lip, buccal mucosa or adjacent to denture flange. They are tender, have a yellowish-grey floor of fibrin slough and red margins, Fig. 16.1. Inflammation, swelling and erythema are variable, depending on the cause and time since trauma. There is no inervation unless the site is scarred from repeated episodes of trauma. Occasionally, a large ulcer is caused by biting after a dental local anesthetic, see Fig. 40.1. Biting trauma may produce 2 small adjacent ulcers matching cusps of upper and lower opposing teeth, Fig. 17.17. Fig. 16.1 A large traumatic ulcer on the lower lip. Note the color of the fibrin slough, distinct from the keratin of a white patch, and the well-defined epithelial margin with minimal inflammation. Chemical trauma is usually accidentally self-inflicted or iatrogenic. Very corrosive agents such as silver nitrate and trichloroacetic acid are now rarely used in dentistry, but etchant, hypochlorite and some tooth whitening agents are just a few of the caustic agents that can cause mucosal ulcers after sometimes quite short contact time, Fig. 16.2. Some patients continue to believe that aspirin is effective for toothache if held against the alveolus to dissolve. The result is local whitening caused by epithelial necrosis, followed by ulceration. Traumatic ulcers heal in days after elimination of the cause. If they persist for more than 10 days without reduction in size and symptoms, or there is any other cause for suspicion as to the cause, biopsy should be carried out to exclude other diseases. Biopsy is not otherwise helpful because the histological features of traumatic ulcers are of non-specific inflammation and repair only. Eosinophilic ulcers and traumatic ulcerative granuloma. This is a related series of presentations with confusing names. When presenting as a flat or deeper punched-out ulcer, the name eosinophilic ulcer is used. When an ulcerated mass forms, the names traumatic ulcerative granuloma or traumatic ulcerative granuloma with stromal, eosinophilia, TUGSE, may be used. However, these conditions have nothing to do with eosinophilic granuloma of bone and do not contain granulomas histologically. The cause is unknown, but an unusual response to trauma is suspected, though a history of trauma is not always obtained. Eosinophilic ulcers have a worrying presentation, often resembling carcinoma and exceeding 10 mm in diameter and enlarging rapidly. Before stabilizing, the ulcers are usually on the tongue but also develop on the gingiva and, occasionally, other sites. Most are in adults of middle age or older, but a characteristic presentation is in infants in the first year of life where erupting lower incisors repeatedly traumatize the ventral tongue or lower lip when feeding, regurgitated disease, Fig. 16.3. A concerning feature is failure to heal, and eosinophilic ulcers may persist for many months, during which the cellular inflammatory infiltrate in the deeper tissues proliferates, raising the mucosa to produce an ulcerated nodule. It is these nodular ulcerated lesions that are sometimes called traumatic ulcerative granulomas, with stromal eosinophilia or tugs. The dense inflammatory infiltrate produces firmness in the underlying tissues, which may be misinterpreted as induration, and the clinical appearance strongly suggests carcinoma or other malignant disease, Fig. 16.4. Fig. 16.2 Chemical burn. The gingivae are wide and necrotic around the central incisors, left lateral incisor and canine following injudicious use of a caustic agent. On the patient's right side, an ulcer is present around the lateral incisor and canine. Fig. 16.3 Traumatic ulcerative granuloma of the tongue caused by the lower incisors, regurgitated disease. From Eichenfield LF, Frieden IJ, Esterly MB, 2008. Neonatal Dermatology, 2nd ed. Edinburgh, Saunders. On the lateral border of tongue, above, strongly resembling squamous carcinoma. Despite the mass and ulcer enlarging further, it resolved completely in 6 weeks, below. In practice, lesions usually heal spontaneously within 3 to 10 weeks, but biopsy will often trigger more rapid resolution. Pathology biopsy is usually undertaken to exclude carcinoma or malignant disease because of size, induration and failure to heal. It is therefore unfortunate that the histological appearances can also be worrying and somewhat resemble some types of lymphoma. A mixed inflammatory infiltrate of eosinophils and pale macrophages and endothelial cells extends deeply, disrupting underlying tissues, and there may be suspicion of cytological atypia and mitotic activity. The presence of CD30+ activated lymphocytes and clonal T-cell receptor populations in some cases are suggestive of lymphoma but probably reflect an abnormal inflammatory or immunological response causing persistence of inflammation and recruiting the numerous eosinophils into the tissues. It is the prominent eosinophils histologically that give the condition its name. Factitious ulcers in the mouth are rare and usually associated with psychosocial disorders in which the patient gains benefit from producing their lesions in some way or another. The dentist must be aware that this presentation may signal a significant mental health condition with a risk of other types of self-harm including suicide. The usual presentation is a non-healing ulcer in the anterior mouth, often easily visible, caused by repeated physical trauma, but presentation and methods of inducing the injury are diverse, box 16.1. Even self-extraction of teeth has been reported. Biopsy may be performed to exclude organic disease or when persistent trauma causes fibrosis that is mistaken for induration of malignant disease. Underlying mental health conditions are typically concealed, and definitive diagnosis is often difficult. Once suspected, multidisciplinary management with medical specialties should be initiated without delay. Self-harm is also a recognized manifestation of a variety of medical conditions: autism spectrum disorders, familial dysautonomia, Lesch-Nyhan and Tourette syndromes and other causes of learning disability, and is common in people living in institutions. Unintended factitious injury can also follow repetitive habits such as picking at the gingival margin with a fingernail, but the degree of trauma is then minor and ulcers rarely develop, though considerable damage to the periodontium may result, even causing tooth exfoliation. Mouth guards, barrier appliances and cognitive behavior therapy may be required. BOX 16.1 Featur ESSUGGES Dive OFFAC to show us OILLESIONS. Lack of correspondence with any recognizable disease, bizarre configuration with sharp outlines, usually in an otherwise healthy mouth, clinical features inconsistent with the history, in areas accessible to the patient. Lack of response to any or all conventional treatments. Case series PMID, 7,776,171 recurrent aphthous stomatitis summary charts 15.2 and 16.2 pp. 280, 311 recurrent aphthous stomatitis is the most common oral mucosal disease and affects as much as 25% of the population at some time in their life. Many cases are mild and no treatment is sought. There are 3 presentations of recurrent aphthous stomatitis, often called recurrent aphthous ulceration or just recurrent aphthy, each of which is defined by its clinical presentation. Ulcers similar and sometimes identical to aphthous stomatitis can be a feature of other diseases or syndromes. Whether these are truly aphthous stomatitis or mimics is unclear. Table 16.1. Recurrent aphthy are rare in older people, particularly the edentulous, unless affected by hematological deficiency. The great majority of patients are of high or middle socioeconomic status and are non-smokers. Many patients have prodromal symptoms of pricking or sensitivity at the site for a few hours or a day before the ulcer forms. There is a brief period of erythema before the ulcer appears. The ulcers have a smooth, sharply defined margin with an erythematous rim in the enlarging phase. The erythematous rim reduces once the ulcer reaches its full size, and while it heals, the margin becomes irregular or less well defined. Typical features common to all types of recurrent apathy are summarized in box 16.2. Table 16.1 diseases in which the ulcers have the features of recurrent aphthous stomatitis, not including those associated through deficiency states. Disease features Behçet's disease. See text. Magic syndrome. Mouth and genital ulcers with inflamed cartilage, a variant of Behçet's disease with relapsing polychondritis. BFAPA syndrome. Ch. 31. Periodic fever, aphthous stomatitis, pharyngitis, and cervical adenitis, a disease of young children of unknown cause, usually treated with steroids, ultimately self-limiting. Probably a genetic auto-inflammatory disease mediated by an abnormal interleukin-1 beta response. Monthly fever rising as high as 41 degrees Celsius for 3 to 5 days with mucosal inflammation and enlarged nodes. Completely asymptomatic between attacks. HIV infection. Ch. 30. Often associated with ulcers of major aphthous type. Minor aphthous stomatitis is the most common type, and the usual history is a single, or crops of several, painful ulcers recurring at intervals of a few weeks. Minor apathy affect almost exclusively the non-keratinized mucosa, usually the labial and buccal mucosa, sulcuses, or lateral borders of the tongue. Fig. 16.5. Individual minor apathy persist for 7 to 10 days, then heal without scarring. Often all ulcers in a crop develop and heal more or less synchronously. Unpredictable remissions of several months may be noted. In severe cases, ulcers are more numerous, and new crops may develop and heal continuously at different sites, without remission. Major aphthous stomatitis is rare and causes single large ulcers, occasionally 2 or 3 at a time. These are much larger than in the minor form. 20 mm diameter is not unusual, and persist for many weeks. The pain of major apathy can interfere with eating. They usually affect the soft palate, fauces, buccal mucosa and lateral tongue. Fig. 16.6 and 16.7. This type may occasionally develop on keratinized mucosa and often heal with scarring. Ulcers can be designated as major form on the basis of size, duration, or both. A cutoff diameter of 10 mm is often taken as the upper limit of the minor form, but size should not be an absolute criterion. Herpetiform aphthous stomatitis is also rare and causes crops of many tiny ulcers, as many as 100 at a time, usually in the floor of mouth and ventral tongue. Fig. 16.8. The background mucosa is red, giving a resemblance to herpetic ulceration, but viral infection is not the cause. The 3 types are summarized in box 16.3. Fig. 16.5. Aphthous stomatitis, minor form. A single, relatively large shallow ulcer in a typical site. There is a narrow band of periulcer erythema. These features are non-specific, and the diagnosis must be made primarily on the basis of the history. BOX 16.2 TYPICALFEA TER ESOFRE KER RENTAPHDHAE. Onset frequently in childhood but peak in adolescence or early adult life. Attacks are variable but sometimes relatively regular intervals. Most patients are otherwise healthy. A few have hematological deficiency. Most patients are non-smokers, usually self-limiting eventually. Ulcers often preceded by prodromal symptoms. Ulcers almost never occur on keratinized mucosa. Fig. 16.6. Aphthous stomatitis, major type. This large, deep ulcer with considerable surrounding erythema has been present for several weeks. Fig. 16.7. Recurrent aphthous stomatitis, major type. The same ulcer shown in Fig. 16.6, but healing. The ulcer is much smaller, but there is puckering of the surrounding mucosa from scarring. Etiology. The main factors thought to contribute are shown in box 16.4. None completely explain the disease, but different factors may apply to different individuals or subgroups of patients. Genetic factors. There is good evidence for a genetic predisposition. The family history is often positive, and the disease affects identical more frequently than non-identical twins. No genetic marker has been found, though polymorphisms in inflammatory signaling genes have been proposed, and some patients have abnormal interleukin-1 beta and interleukin-6 levels. A number of genetic auto-inflammatory diseases are known to be caused by loss of function in genes controlling inflammation. Ch. 31, and several include aphthous stomatitis-like ulcers, but with additional systemic features. The concept that aphthous stomatitis is a genetically mediated auto-inflammatory disease is appealing, but, as yet, unproven. In the possibly related Behçet's disease, see later in this chapter, the evidence for a genetic predisposition is much stronger. Fig. 16.8. Recurrent aphthous stomatitis, herpetiform type. There are numerous small, rounded and pinpoint ulcers, some of which are coalescing. The surrounding mucosa is lightly erythematous and the overall picture is highly suggestive of viral infection, but the attacks are recurrent and no virus can be isolated. BOX 16.3 TYPESOFRE KER RENTAPHDHAE minor apathy. The most common type, non-keratinized mucosa affected. Ulcers are shallow, rounded, 3 to 7 mm across, with an erythematous margin and yellowish floor. One or several ulcers may be present. Major apathy, uncommon. Ulcers frequently several centimeters across, sometimes mimic a malignant ulcer. Ulcers persist for several months. Masticatory mucosa, such as the dorsum of the tongue or occasionally the gingivae. may be involved. Scarring may follow healing herpetiform aphthy, uncommon, non-keratinized mucosa affected. Ulcers are 1 to 2 mm across, dozens or hundreds may be present, may coalesce to form irregular ulcers, widespread erythema around the ulcers BO. X16.4 po SSIBLEAETOLOGECALFACTORSFORECORENTAPHTHAE, genetic auto-inflammatory predisposition, exaggerated response to trauma. Infections. Immunological abnormalities, gastrointestinal disorders, hematological deficiencies, hormonal disturbances, stress trauma is often blamed by patients. There is some evidence that minor trauma is more likely to develop into an ulcer in a susceptible individual, and most ulcers are on the less trauma-resistant lining mucosa. The evidence for this is stronger in Behçet's disease. Infections. There is no evidence that aphthy are directly due to any microbes either causing infection or triggering immune reactions. An extensive range of oral commensals, pathogens, bacteria, viruses and unusual organisms such as mycoplasmas and forms have been investigated fruitlessly. Immunological abnormalities. The formation and healing of an ulcer involves inflammatory and immune mechanisms, but there is no evidence any are causal and the disease is not autoimmune. There is no association with atopy or other known allergens despite many patients linking ulcers to dietary components. Aphthy lack virtually all features of typical autoimmune diseases. They also fail to respond reliably to immunosuppressive drugs and become more severe in the immune deficiency state induced by HIV infection. Food allergy is often claimed by patients but not supported by direct evidence. It is possible that gastrointestinal effects of food allergy could cause mild deficiency states and that these could predispose or worsen pre-existing aphthous stomatitis. Dietary elimination of individual suspected allergens has not been shown to affect severity or incidence, but response have been shown with strict general exclusion diets. Gastrointestinal disease. Aphthy are only rarely associated with gastrointestinal disease such as celiac disease, and then as a result of a deficiency secondary to malabsorption, particularly of vitamin B12 or folate. Hematological deficiencies. Deficiencies of vitamin B12, folate or iron have been reported in as many as 20% of patients with aphthy, though they can also be common in the healthy population. Such deficiencies are more frequent in patients whose aphthy start or worsen in middle age or later, have more than 3 ulcers at a time or very frequent or unremitting attacks. In many such patients, the deficiency is latent, the hemoglobin is within normal limits, and the main sign is micro or macrocytosis of the red cells. In patients who thus prove to be iron, vitamin B12 or folate deficient, remedying the deficiency may bring rapid resolution of the ulcers. Zinc deficiency. Zinc deficiency has been found to be more common in aphthous stomatitis patients, but the significance is unclear. Hormonal factors. In a few women, aphthy are associated with the luteal phase of the menstrual cycle, but there is no strong evidence that hormone treatment is reliably effective. Pregnancy is often associated with remission. Stress is often related to exacerbations according to patients, and some studies have reported a correlation. However, stress is notoriously difficult to quantify, and some studies have found no association. HIV infection. Aphthous stomatitis is a recognized feature of HIV infection. Its frequency and severity are related to the degree of immune deficiency, as discussed later. Not smoking. It has long been established that recurrent aphthy is a disease, almost exclusively, of non-smokers, and this is one of the few consistent findings. Recurrent aphthy may also start when smoking is abandoned, but restarting does not induce remission, and quitting using nicotine supplements seems to prevent this. The reasons are unclear. In summary, deficiencies of iron, folate or vitamin B12 are the most significant predisposing factors because these may be secondary to another more significant condition and because addressing them may cure or ameliorate the condition. Pathology biopsy plays no role in the diagnosis except to exclude carcinoma in the case of clinically worrying major aphthy or to exclude viral infection in herpetiform aphthy. If performed, biopsy in the prodromal phase reveals an initial lymphocytic infiltration of the epithelium, followed by destruction of the epithelium and non-specific acute and chronic inflammation, Fig. 16.9. Aphthy are not preceded by vesicles. Diagnosis is almost exclusively by history, primarily recurrences of self-healing intraoral ulcers at fairly regular intervals. Almost the only other condition with this history is Behçet's disease. Usually occasional ulcers are tolerated, and it is an increase in frequency of ulcers that brings the patient to seek treatment. A detailed history of the ulcer number, shape, size, site, duration, frequency of attacks is required. Most patients appear well, but hematological investigation is particularly important in older patients and those with recent exacerbations in frequency of crops, ulcer size or pain. Routine blood indices are informative, and usually the most important finding is an abnormal mean corpuscular volume, MCV. If macro or microcytosis is present, further investigation is necessary to find and remedy the cause. Treatment of vitamin B12 deficiency or folate deficiency is sometimes sufficient to control or abolish aphthy. Applying the most sensitive tests for iron, folate and B12 deficiency identifies more patients who can benefit from treatment, and they will often respond to supplementation despite apparently having very mild or early deficiency. Key features for diagnosis are shown in Table 16.2. Fig. 16.9 16.9 Recurrent aphtha. Section of an early ulcer showing the break in the epithelium, the inflammatory cells in the floor and the inflammatory changes more deeply where numerous dilated vessels can be seen. Table 16.2 Management. Apart from the minority with underlying systemic disease, treatment is empirical and palliative only. Despite numerous clinical trials, no medication gives completely reliable relief. Low potency and topical agents should be tried first. Some patients report that changing toothpaste is helpful. Reassurance and education. Patients need to understand that the ulcers may not be curable but can be made bearable with symptomatic treatment. Reducing the number of attacks is more difficult to address, but some treatments are successful, particularly if attacks are frequent. The condition usually wanes eventually of its own accord, although after many years. Corticosteroids. Some patients get relief from hydrocortisone, 2.5 mg, oromucosal tablets allowed to dissolve next to the ulcer 3 times per day. These low-potency corticosteroids adhere to the mucosa to provide a high local concentration of drug and are suitable for use in dental practice. They probably reduce the painful inflammation but do not speed healing much or reduce frequency of attacks. They are best applied in the very early, asymptomatic stages. Triamcinolone dental-based. Triamcinolone dental-based, accorlein or Abase, acts similarly but is no longer available in the UK and is superseded by the previously mentioned mucosal adhesive tablets. Tetracycline mouth rinses. Trials in both Britain and the United States showed that tetracycline rinses significantly reduced both the frequency and severity of aphthy. However, the reasons are unclear and this is best reserved for herpetiform aphthy as these respond reliably. The contents of a tetracycline capsule can be stirred in a little water and held in the mouth for 2 to 3 minutes, 3 or 4 times daily. However, there are few easily soluble tetracycline preparations, and repeated use carries a risk of superinfection by Candida albicans. Doxycycline, 100 mg, dispersible tablets are a suitable preparation. The solution should not be swallowed. Chlorhexidine. A 0.2% solution has also been used as a mouth rinse for aphthy. Used 3 times daily after meals and held in the mouth for at least 1 minute, it has been claimed to reduce the duration and discomfort of aphthous stomatitis. Topical salicylate preparations. Salicylates have an anti-inflammatory action and also have other local effects. Preparations of choline salicylate in a gel can be applied to aphthy. These preparations, which are available over the counter, appear to help some patients. Local analgesics. These provide only symptomatic relief, but benzidamine mouthwash or spray helps some patients. Topical lidocaine or benzocaine sprays and gels are more effective but can only be used in limited doses and for a short time. They do not require prescription in the UK. Treatment of major aphthy. Major aphthy, whether or not there is underlying disease such as HIV infection, may sometimes be so painful, persistent and resistant to conventional treatment as to be disabling. Reportedly effective treatments include azathioprine, cyclosporin, colchicine and dapsone, but thalidomide is probably most reliably effective. Their use may be justified for major aphthy even in otherwise healthy persons if they are disabled by the pain and difficulty of eating. However, such drugs can only be given under specialist supervision. Complementary and experimental treatments. Common, relatively inconsequential diseases that are difficult to treat will always be used to promote treatments without a good evidence base. While the disease remits spontaneously and unpredictably, and measurement of symptoms is imprecise, it is difficult to prove whether such treatments are effective or not. Possible treatments for recurrent aphthy are summarized in Appendix 16.1. RAS Review PMID, 21,812,866 and 17,850,936 Disease Association. However, it is a systemic vasculitis of small blood vessels and affects many more organ systems than suggested by this limited definition. The importance of making the diagnosis is indicated by the life-threatening risk of thrombosis, of blindness or brain damage in a small number of patients. Clinical Behçet's disease is particularly common in Turkey *operator, Central Asia, the Middle East and Japan but is less common in emigrants from these areas and is rare in people from Europe, the Americas and Africa. This matches the geographic incidence of the human leukocyte antigen, HLA, B51 allele, see later in this chapter. Fig. 16.10 Erythema nodosum. This is the commonest skin manifestation of Behçet's disease. From Habib, F. 2004. Clinical Dermatology, A Color Guide to Diagnosis and Therapy, 4th ed. Mosby, Philadelphia. Patients are usually young adult males between 20 and 40 years old and they can develop 1 or more of 4 patterns of disease. Mucocutaneous. Oral aphthy are the most consistent feature, are not distinguishable from common aphthous stomatitis and may be of any of the 3 types. There is often genital ulceration and a variety of rashes including erythema nodosum, Fig. 16.10, and vasculitis, Fig. 16.11. Arthritic. Joint involvement with or without mucocutaneous involvement. The large weight-bearing joints are most affected. There is pain, but no destructive arthritis and only a few joints are involved. The pain may be relapsing or constant. Neurological. This type may occur with or without other features and is usually a late stage. Vasculitis within the brain causes a variety of neurological symptoms including sensory and motor disturbances, confusion and seizures. Thrombosis of vessels causes raised intracranial pressure, blurred vision and headache. Ocular. This type may also be solitary or accompany other types. There may be uveal inflammation or vasculitis and thrombosis of the retinal arteries, either of which can lead rapidly to blindness if not treated. Behçet's Review PMID, 345240077, updated annually. And 34,531,393 etiology. The etiology is unknown, but the disease has features including circulating immune complexes, high levels of cytokine secretion and activation of lymphocytes and macrophages in the circulation. These suggest an immune-mediated reaction, and it is presumed that this may be a response to an unknown infectious agent, possibly through immune cross-reaction between pathogen and host heat shock proteins. Fig. 16.11 Thrombophlebitis in Behçet's disease. Inflammation and pigmentation highlight the sites of veins, arrow, and their valves. The ethnic distribution suggests a strong genetic component and HLA tissue types are linked, most strongly to HLA-B51. This is a common allele in the healthy population and so is not of use in diagnosis but can predict ocular lesions in those who do have the disease. Diagnosis and management. Oral aphthy are frequently the first manifestation. Behçet's disease should therefore be considered in the differential diagnosis of aphthous stomatitis, particularly in patients in an ethnic group of risk, and the medical history should be checked for the features shown in Table 16.3. The frequency of other manifestations is highly variable. As a result, there are no absolute criteria or reliable tests for the diagnosis, but in a dental setting, aphthous stomatitis in combination with any two of the other major features can be regarded as likely indicators meriting referral of the patient. Tests are not helpful in diagnosis, apart from the pathology test. The test is positive if there is an exaggerated response to a sterile needle puncture of the skin. However, the test must be interpreted by an experienced clinician and tends to be positive only in patients from the Mediterranean region. Moreover, a positive pathology test does not correlate with the presence of oral lesions or with the overall severity of the disease and is rarely positive in patients from the UK. It is also not entirely specific for Behçet's disease but has a specificity over 90% in susceptible populations. The international criteria for Behçet's disease system is shown in Table 16.3. Cyclosporin and tacrolimus are the main treatments, with steroids for acute exacerbations. Thalidomide or topical tacrolimus are most effective for oral ulcers. Anti-tumor necrosis factor alpha drugs such as infliximab are a promising recent option, but a wide range of treatments are used for specific conditions. Table 16.3 operator a score of 4 or more points predicts Behçet's disease with 95% certainty, 98% if the pathology test is performed. Incidence of features varies between populations. 100% using older criteria, previously a requirement for diagnosis. The high figure is for patients from the Middle East and Central Asia. Complications include blindness, rupture of large vessel aneurysms, thrombosis and embolism, but in the absence of these and other significant complications, relapses become less frequent, and the disease may eventually burn out. HIV-associated oral ulcers. People with HIV infection, CH 30, are susceptible to severe recurrent aphthy that are not otherwise distinguishable from common aphthy. They may be of any of the three types, but most are either major or herpetiform aphthy. With declining immune function, the ulcers become more frequent and severe but improve on effective antiretroviral treatment. Aphthy are no more frequent in HIV infection than in the healthy population and are classified with group 3 lesions, CH 30. Ulcers whose presentation does not match the three patterns of aphthy are classified just as HIV ulceration, previously atypical ulceration. Biopsies should be taken from non-healing ulcers to exclude opportunistic infections and other HIV-associated conditions including lymphoma, Epstein-Barr virus or Cytomegalovirus ulcers and deep fungal infections. Treatment with potent topical steroids is frequently effective. In severe cases, ulcers require the higher potency drugs listed for aphthous ulcers, often systemically, Appendix 16.1. Description PMI. Ulcers have been reported to affect 5% of patients on the drug, but this is likely an overestimate. Ulcers usually appear within 24 months of starting the drug, often after a few weeks, and are usually solitary and on the lateral tongue, buccal mucosa, gingivae or fauces. Perianal or vulval skin are the usual skin sites. Ulcers can arise at relatively low doses, although they are common at higher dose. Fig. 16.12 Nicrandyl-induced ulcer. The ulcer appears sharply demarcated and has no well-organized slough or granulation tissue in the base, A. Healing took 9 weeks after drug withdrawal and a scar remains, B. From Yamamoto, K. Matsusu, Y. Harita, S. A. al. 2011. Nicrandyl-induced oral ulceration, report of 3 cases and review of the Japanese literature. Oral surg. Oral med. Oral pathol. Oral radial. Endod. 112, 754-759. The oral ulcers have a characteristic clinical appearance and are strikingly painful, Fig. 16.12. They're deep, with a punched-out or overhanging margin, and range from 1 to 3 cm in diameter. They may be mistaken for major aphthy or carcinoma. Ulcers do not usually respond to local medications and persist for several months unless the drug is withdrawn, when they heal within a few weeks depending on their size. Nicrandyl is known to delay wound healing, and biopsy shows reduced formation of granulation tissue in the ulcer base. However, the features are non-specific, and biopsy does not aid diagnosis other than to exclude other causes. Case series PMID, 15,920,586 and 29,760.